תודה רבה, אלי. אני שמח מאוד להיות פה היום בתל אביב, אבל... סליחה. I will switch in English. My Hebrew is poor. So it's my pleasure to present to you today the results of this collaborative study, primary PCI for STEMI in nonagenarians. It's a collaborative study between three countries, France, England, and Israel. The data are coming from the acute coronary syndrome Israeli survey, and data have been provided kindly by Amit Segev. As you know, primary percutaneous coronary intervention is the gold standard in the general population, but there were limited available data on primary PCI in very old patients, I mean in nonagenarians. And it's a growing population. And also coronary artery disease remains the leading cause of morbidity and mortality in these patients. And as you know also, patients over 75 years old are usually excluded from clinical trials. And perhaps we fear that coronary angioplasty will be at increased risk of bleeding and perhaps mortality. The first case of primary PCI in a nonagenarian was published 15 years ago. It was a 90-year-old female. She had an acute myocardial infarction and she got a successful PPCI. Therefore, we have included retrospectively 145 patients, nonagenarian patients with acute myocardial infarction admitted and treated for primary percutaneous coronary intervention between January 2006 and March 2013. The data come from three sites in France, La Pitié-Salpêtrière, Bichat, and Versailles, from Newcastle in UK, and as I said, from Israel. Patient characteristic, mean age was 92, the oldest was a female, 102. There were low comorbidity profiles, as you see, for example, diabetes was only present in 14% of the cases. The clinical presentation at admission was relatively severe. 43% of the patients has a KILIP class 2 to 4, and about 1/3 of the patients were admitted with a pulmonary edema or cardiogenic shock. The biological data, we can notice that the LDL cholesterol was low, less than 1 gram per liter. 1/3 of the patients having been treated before the admission with statins. What about the antithrombotic management? Aspirin was given to almost all of the patients, and inhibitors of P2Y12 inhibitors was given very largely. Usually it was, of course, a loading dose of clopidogrel. Heparin was used in most of the cases, 90% of the cases, mostly unfractioned heparin. And it is interesting to note that glycoprotein 2B3 inhibitors were used in about 1/3 of the patients. Sorry. The angiographic data are the following. Median time for symptoms onset to PCI was less than 4 hours. The radial access was used in 60% of the cases. The main artery that was treated was, of course, LAD and the right coronary artery, and thrombus aspiration was only attempted in 14% of the patients. The angiographic data show that we got successful revascularization in 86% of the patients. We use inotropic support in 26% of the patients. In-hospital outcomes are the following. Death occurred in 24% of the patients. We have very few major bleeding and acute renal failure. Medical treatment as discharge was, of course, mainly dual antiplatelet therapy with aspirin and clopidogrel, and PPI statins were administered in 80% of the cases, beta blockers in 2/3 of the patients. The long-term outcome is the following. 6-month survival was 61%, 12 months was 53% with an almost complete follow-up. these results are comparable to other previous data with less patients, 68% of survival at 6 months, 67 for these two studies. In conclusion, we can say that this is the largest series to date with the longest follow-up in nonagenarians treated with PPCI. This cohort is coming from several centers in different countries. Primary percutaneous coronary interventions in nonagenarians may improve the in-hospital and mid-term outcomes. Our data support the use of primary PCI in selected nonagenarians patients, of course, and PPCI seems feasible in very old patients with a low rate of complications, a high rate of successful procedures, and a low rate of mortality than expected. The regular approach may be routinely chosen by experienced operators, but of course, this is not a randomized study. Frail elderly were, of course, excluded by the operators. And this is only a way to say that in selected old patients, PPCI seems feasible. This has been published in Heart last year. Thank you for your attention.
I'd like to know if you compare this group, this cohort, with the group of patients, non-nonagenarians that got the best medical treatment under MI.
Of course, this is...
What do you mean selected group? How do you select this group?
In fact, this is a good question. The selection was done by the operators. When they got the call, do you want to do the PCI for this patient? He is 95-year-old. The question was, but it depends on in the centers. Do you think he is very sick? How is it? And of course, it's only the strongest people that got PPCI. So we have no idea of the real comparison with the medical treatment, of course.
To rephrase the question, do you know the recent registry that looked at conservative medical treatment in nonagenarians, whether the outcome of mortality is much higher?
No, in fact, no. The answer is no. There are some reports for octogenarian patients, but for nonagenarian patients, I have no data to give you.
And do you have any information on those centers that you have all the data on how many patients were taken to the cath lab and PCI was not done? And what was their prognosis?
In fact, the prognosis, I don't know this prognosis. And in fact, the first part of the question is also difficult. I guess it's about 1/3 of the patients only that were admitted for PPCI. But once again, it's very different from one center to another. So it's very difficult to give absolute numbers and true numbers.